Welcome to our continuation lecture of Chapter 10. We're just going to continue from the slide that we left off in class, starting from slide, I believe, 19 here. So we were talking about the mechanisms of breathing, and this is really done in two different phases of breathing or ventilation. Remember, ventilation is just bringing that air in down through our bronchial tree. So our two phases are called inspiration and expiration. Inspiration is also the same thing as inhalation. So this is going to be an active process of inhaling, bringing the air into our lungs. So when you're breathing in, that's inspiration. When you breathe it out, that's expiration. And this is more of a passive process that will help to expel the air out from the lungs. So to assist us in doing this, we have our external intercostal muscles, and these are going to assist us in inspiration. What these muscles do is they contract and lift our rib cage up so we can create more volume, more space for our lungs to inflate. Whereas our internal intercostals, these fibers are moving in an opposite direction. So this is going to help to push down when we forcefully exhale, trying to push the air out of our lungs. So we want to make our thoracic cavity smaller so that we're pushing on our lungs and getting that air to move out. So we want to mention Boyle's law. So I want you to think of this bubble that's created here as our thoracic cavity. Our ventilation process is governed by Boyle's law, and let's discuss what it is. It is a constant, at our constant temperature, when pressure is given a quantity of gas, and it's inversely proportional to its volume. This means as volume increases, pressure is going to decrease. So that's what we're seeing in this top illustration here. We have our volume increasing, that thoracic cavity is getting larger, and so we're going to see that our pressure will decrease. Whereas down here during exhalation or expiration, our volume has decreased. So now we have increased pressure within our cavity. So let's talk a little bit more about inspiration. Our diaphragm and our intercostal muscles are going to contract, specifically the external intercostal muscles. Our diaphragm, naturally, when it's relaxed, it's dome-shaped, like we see here, okay? Like a big dome. So when these muscle fibers contract and shorten, it's actually going to pull this diaphragm down to become flat. So you can imagine as it does this, it's pulling the air down through the trachea and into those bronchi to bring the air down into our alveoli. So our rib cage is moving downward and outward. Our volume within our thoracic cavity and our lungs are going to increase because we need that room for the air to move into our lungs. And fitting in with Boyle's law, the air pressure is now going to decrease. Now the opposite will happen with expiration or exhalation. Our diaphragm, like we said, in its relaxed state will be dome-shaped. So it goes from that flattened contraction from inhalation to its relaxed shape, which is a dome. So as it goes back into its dome shape, it's pushing this air out of the lungs. Our rib cage is going to move downward and inward, and when we forcefully exhale, our internal intercostals will really assist us in pushing that air out. As far as our volume of the thoracic cavity, it's going to decrease, which means our pressure is going to increase, and that causes air to flow out of our lungs. Next, we're going to talk about the different volumes of air during breathing. Now, we can measure our breathing using something called a spirometer, and we're going to use this in our lab 11.2. So when we breathe in a spirometer, it'll tell us the different volumes we're inhaling and exhaling. And we get a graph that looks like the one down here. So first we have our tidal volume. The tidal volume is just a small amount of air that is normally moving in and out of our lungs with each breath as we're just sitting here at rest. Our vital capacity, that is going to be the maximum of air that we can move in, plus the maximum of air that we can move out within one breath. Now our inspiratory and expiratory reserve volume, these are going to be the increased volume of air moving in or out of our body. Inspiratory, of course, is referring to the moving in, and expiratory is the air moving out. And our residual volume, this is the air remaining in our lungs after exhalation. So try and push all the air out of your lungs. So you go, there's still some air left in your lungs, and that air is necessary so that your lung doesn't collapse. Okay, so how is breathing controlled by our nervous system? It's controlled by a specific respiratory center within our brain in the medulla oblongata. So that medulla oblongata is found in the brainstem, and you see it indicated right here. There's actually a respiratory center within the pons as well, and our pons is right here in the brainstem as well. Our respiratory center within the medulla, though, is going to send impulses to contract our muscles for inspiration. Now, unfortunately, there are some babies that suffer from SIDS, or sudden infant death syndrome, and that is thought to occur when this center stops working. So for whatever reason, we're still not sure the exact reason this happens, but we aren't getting the signal from our medulla to have our babies breathe properly. So there are certain things that you can do to ensure that your baby is breathing well, like making sure they're sleeping on their back. This, I believe, they kind of send out a campaign for all babies to sleep on their back, and I think it reduced SIDS by 50% by doing this. Also, making sure there aren't any pillows or blankets around your baby when they're sleeping in their crib or bassinet. Nothing covering the mouth, because they don't have the functionality to pull that away to make sure they're breathing properly. And other things that the mother can do while they're pregnant, making sure they're not smoking, and of course staying healthy altogether. Next, we're going to talk about chemical control. We have two sets of chemoreceptors. Now, these are going to be receptors that sense for chemicals, and we're usually going to find them around our greater vessels that come off of the heart, so the branches that come off of the aorta. And they will sense if there is a drop within our pH and send a signal over to our brain. And the other part will send a signal over to our circulatory system. Both are going to be very sensitive to our carbon dioxide levels, because they're going to be the ones to help change our levels of pH due to metabolism. We'll talk more extensively over this in our lab 11.2, but just so we can understand what's going on here, when we exchange gases within the body, we have this half of our body representing external respiration. External respiration is when we're passing blood, when we're passing components of our blood, the gases in our blood, between our air sacs. So we breathe in and bring in oxygen down into the alveolus here. So here is our oxygen level. It's at 100 millimeters mercury. And because we have a lower amount of pressure within our capillary at 40 millimeters mercury, our oxygen through simple diffusion is going to want to move from the air sac, or alveolus, into the capillary. Now, as we move through this capillary, you'll see that our carbon dioxide has a higher pressure within the capillary than it does in the alveoli. So our carbon dioxide moves from the blood into our air sac so we can breathe that air out. All right. Now, the other part of this happens over here. This is called internal respiration. Internal respiration occurs when we are exchanging our gases, nutrients, and waste from our capillary, our blood in our capillary, into our cells that make up our tissues. So here, our oxygen is going to move from our blood in the capillary into the cell and into our mitochondria, where we'll have cellular respiration take place. Remember, we want oxygen to be utilized in the mitochondria in order to create ATP. So the cell can use ATP for energy. The carbon dioxide that's released as a byproduct of some of those cellular reactions is going to move from the cell into the capillary, into our blood, to be carried back to the heart so it can become reoxygenated. So here again is our external respiration. We are passing oxygen from our alveolus into our capillary, and then our carbon dioxide within our capillary is moving into our alveolus so we can breathe it out. And this is representing a chemical standpoint of our external respiration. So what happens is we have our bicarbonate ion and our hydrogen ion on its own. These will then be driven to become the carbonic acid, and using an enzyme, our carbonic anhydrase, will turn into water and carbon dioxide. Now, to transport our oxygen, we have our hemoglobin molecule, and when our hemoglobin picks up oxygen, we get our oxygenated blood within our capillary. This is just a diagram here showing us the movement of gases during our external and internal respiration. So similar to what we have been talking about, here we have carbon dioxide exiting the blood. So once again, we take that bicarbonate ion, and I know this is really small, so look at it in your textbook if you can't really see well here. But we're going to have most of this bicarbonate ion sitting within the plasma of our blood, that watery portion of our blood. And when it moves into our red blood cell, it's going to combine with our hydrogen ion to become that carbonic acid, and then react with our enzyme to divide into the water molecule and carbon dioxide. That'll move into our alveolus. That again is external respiration. At the same time, we're having the oxygen in the alveolus moving into our red blood cell and attaching to our hemoglobin molecules. Now when we move into our internal respiration down in here, this is when our blood is giving its gases over to our cells or tissue cells. So here we have our red blood cell, and we can see that our cells have gone through their metabolic processes and have that byproduct of carbon dioxide. So our tissue cell is then going to give that carbon dioxide over to our red blood cell. This carbon dioxide molecule combines with our water molecule to become that carbonic acid molecule. This then will dissociate to become our bicarbonate ion and move into the plasma and our hydrogen ion. Whereas when we're talking about our oxygen, we want to take our oxygen in our red blood cell within our oxygenated blood and detach from our hemoglobin molecule and drive it into our tissue cell to give that cell enough oxygen to move into the mitochondria, that organelle of our cells, and create ATP for the cell to use for energy. So here's our internal respiration. We already talked about this. We have our oxygen moving from the blood into our tissue cells and carbon dioxide moving out of the cell and into our capillary to be pumped back to the heart. So when we have oxygen bound to hemoglobin, we call it oxyhemoglobin. So here we have deoxyhemoglobin. So each of our subunits that has that iron molecule do not have the oxygen attached. So that's why we call it deoxyhemoglobin. Once our oxygen molecules attach to our subunits, this is now called oxyhemoglobin, which helps to make up our oxygenated blood. Like I mentioned, most of our carbon dioxide is carried as our bicarbonate ion. So when we have our carbon dioxide, it starts to combine with water to become our carbonic acid and will dissociate into the, excuse me, sorry about that, will dissociate into the bicarbonate ion and hydrogen ion. Now we're going to talk about some upper respiratory tract infections. So the first one is going to be sinusitis. Sinus is just an empty space within our bone in our skull. And itis, anytime you see that suffix, that means inflammation. So here we have a blockage of these sinuses here, okay? Whereas the other side, we have healthy sinuses. We got a mucus lining and no buildup of mucus there. Otitis media, this is going to occur in the middle ear where we have those 3 small bones of the ear, and we get an infection in this area. So this is actually showing us the tympanic membrane or the eardrum, and it's swollen and inflamed. Tonsillitis, we take the word tonsil, and itis means inflammation. So this is just an inflammation of the tonsil. This is actually the uvula back in here that has been obstructed by the palatine tonsil, because the palatine tonsils are so infected here. You could see the pus from the bacteria that is infected in here, that it's obstructing that uvula. Here would be the anterior pillar, and we can't even see the posterior pillar surrounding the tonsil because this is so inflamed. We can also have laryngitis. We mentioned this in class a little bit. When you lose your voice. And so here's our false vocal fold, this and this here, whereas these folds here, that's our true vocal fold. So this vocal fold has been infected and inflamed, and so they're not going to be able to work properly in order to assist in its main function, which is vocalization. As far as lower respiratory tract disorders, you may have heard of many of these. We have pneumonia. This is going to be an infection of the lung with thick fluid buildup. So here's our healthy alveoli, nice and pink, no buildup of mucus, whereas these are starting to fill up with the fluid. Of course, when we have fluid in here, we're not going to get proper functioning of the alveoli, so we won't have gas exchange occurring as well. Next, we have tuberculosis or TB. And this is a bacterial infection that's going to lead to tubercles within our lungs. And basically what that is areas of encapsulated bacteria. So here's the initial infection in this upper right lobe. We can see that that plaque is going to progress and start to build a hole. And then, of course, it can become more progressive, and we have numerous cavities, numerous tubercles here in the lung. When we have pulmonary fibrosis, these are going to be when our lungs start to lose their elasticity, and this is due to the fibrous connective tissue that's going to build up in our lungs. So our lungs have these lobules that in between, they'll have a connective tissue septa, a connective tissue wall. So these are the areas that are being affected and losing the elasticity, so that when our lungs inflate, we have a hard time kind of pushing back and recoiling because of the loss of the elastic fibers here, the elastic tissue. So as a result, we're going to have damaged bronchioles. Remember, those are the small bronchi and alveolar sacs. Now, we don't want to lose the shape or the the increase in surface area of our alveoli, because that's going to reduce the amount of gas exchange that can occur between all of our alveoli. So we get scarring of the lungs, and we see a buildup of all of this scar tissue. Other lower respiratory tract disorders are going to be emphysema. Now, this is a chronic incurable disorder in which our alveoli become damaged. So these areas where we would have these nice little sacs here, they start losing those sacs and fuse into one big sac. So now we're losing that surface area for gas exchange, and it's reduced. So people with emphysema, and here's on a cadaveric lung of what emphysema looks like. People with emphysema will usually dramatically lose a lot of weight because they have to work so much harder to breathe in order to get enough oxygen to all of their tissues. Next we have asthma. And asthma is usually when we have a hypersensitivity to something. Maybe it's pollen in the air, and our bronchial tree becomes irritated. So here's our normal diameter of our bronchi. Remember, these are tubes moving down into our lungs. So it's helping us with ventilation, moving the air down to our alveoli. So when we do come into contact with something we're hypersensitive to, it triggers our bronchioles to thicken up and become inflamed, maybe secrete some more mucus too in certain people. And so that's going to start to constrict this bronchial tube. So we're not going to be able to move the air down as well as we did before. Our smooth muscle is going to assist us in creating a more narrowed airway here as well. So our symptoms would be breathlessness, wheezing, and or coughing. Now, as far as lung cancer, we can have our lung cancer happen in both men and women equally. It is uncontrolled cell division, so we get an abnormal type of cell division, and it happens very quickly. And so we get a development of a tumor within the lungs. Usually it starts out within one lobe, so hopefully it's located just in one bronchopulmonary segment, which, just to refresh your memory, let me grab a pen here, that's going to be little sections of each of our lobes here. Okay, each of these are like a bronchopulmonary segment. So it just sections off some of the lobes, some of the lobules, I should say, of a lobe of the lung. So if a tumor is located in one of those bronchopulmonary segments, we can remove that portion in hopes that the cancer won't come back. And usually lung cancer's main cause is going to be smoking, which can lead to death. So here are some diseases and disorders of our respiratory system that we already talked about. Here we have pneumonia, where we have fluid filling up each of the alveolar sacs here. We have pulmonary fibrosis, where we get the fibrous connective tissue losing elasticity, and we're going to not be able to recoil the alveoli as well. We have tuberculosis, where we get tubercles encapsulating bacteria, which will also reduce the elasticity of our lung. We have emphysema that ruins our alveolar walls and creates one big alveoli instead of having our small alveoli, which would increase surface tension. Asthma, we have constricted airways, and bronchitis is just an inflammation within our bronchi or bronchioles. So the last thing I want to talk about, I believe this is our last slide. Yes, it is, and I just exited out. Let me go back. Sorry about that. Here we go. Okay, now our last slide is about tobacco and health. Now, we talked a little bit about this in class. Here's our healthy lung. Like I said, this is all from just normal air pollution. And here's a tobacco smoker's lung. Smoking is going to increase your chance of getting lung, mouth, larynx, esophagus, bladder, kidney, pancreatic, stomach, and cervical cancers. Um, it can also increase your chances of chronic bronchitis, emphysema, heart disease, stillbirth, and harm to an unborn child. And even passive smoke can increase a non-smoker's chance of pneumonia, bronchitis, and lung cancer. So most of us have heard of secondhand smoke. So if somebody else is smoking and you're standing next to them, even though you're not smoking the cigarette itself, you're inhaling their smoke. And now there is third-hand smoke. This is the smoke that even after the person who smoked the cigarette, after they've stopped, that smoke settles, all the chemical settles onto their clothing and their hair. And when you're around that person, you are inhaling those chemicals and the smoke components off of their clothes and their hair. So that is third-hand smoke. I also wanted to touch a little bit about the difference when you're smoking marijuana, and there's a recent study in which they followed marijuana users to see how much it affected lung functioning. And so they found that if somebody smoked one joint for every day within 7 years, that they didn't see a significant decrease in the amount, or I should say in the functioning of that individual's lungs, but at more than 10 joints, I'm sorry, let me rephrase this, but if they had a joint every day for 10 years or more, then researchers saw a slight decline within their lung function. Now, more research needs to be done to find out the effects of marijuana on the lungs. This was just one study, and they chose people that would just once in a while use marijuana. So, so you also want to keep in mind that when these people that are sparingly using marijuana who aren't addicted, they're going to seem to pose a lower risk to the lungs than the typical usage patterns of cigarette smoking. So we can say that smoking cigarettes is worse for your lungs as far as lung functioning than smoking marijuana. But don't kind of dismiss the harm that marijuana can do to your lungs as well, like irritating your airways. It can trigger coughing, phlegm production. It could really be dangerous if you have asthma as well. So it's still affecting the lungs. It's just not affecting lung functioning. So don't assume that there is no risk no matter who you are. You just don't know how it's going to affect your body. And smoking marijuana could lead to chronic coughing, wheezing, and potentially COPD, or chronic obstructive pulmonary disease. So that is my little 2 cents about marijuana smoking. If you have further questions, please let me know, and we'll cover majority of this in class as well on Tuesday. And here's the little video that I was discussing in class. I'll also post this link. Let me see if it's going to work for us. I will post this link on Blackboard. So here is our nice and healthy lungs, inflating, nice and pink. And here is a smoker's lung. So you could see that that volume that we get with the healthy lungs is just not even close to what the smoker lungs is inflating to.